This is a PowerPoint on multiple organ dysfunction syndrome and shock. Pathophysiology of MODS includes progressive failure of 2 or more organs. There is a failure to control the inflammatory process, which is SEERS, and that is the etiology. There is excessive inflammatory cells and biochemical mediators, endothelial damage, organ damage, and then subsequently the organ failure. The pattern of dysfunction usually originates in the lungs and continues throughout the organs. In the lungs, there is inflammatory cells and biochemical mediators. They damage the pulmonary vascular and alveolar endothelium. This decreases the surfactant and increases capillary permeability, leading to increased fluid. There is intrapulmonary shunting. This is blood going through the capillary that is not oxygenated. Signs and symptoms include low-grade fever, tachycardia, dyspnea, mental confusion, refractory hypoxemia, decreased pulmonary compliance or stiff lungs. That's due to the decreased surfactant. The chest x-ray will show whiteout, which is ARDS, and they will have increased respiration. Treatment will be intubation and ventilation. In the liver, there is a decreased inflammatory response. They have decreased detoxification of organisms and drugs. They will have jaundice, which is an increase of bilirubin. They will have increased liver enzymes, increased bilirubin and ammonia, and their INR will be high because they will have decreased ability to form clotting factors. They will have decreased albumin and protein. They will have ascites, and the treatment is to rest the liver. In the gallbladder, they will have acalculous cholecystitis. This is there's no stone causing the cholecystitis. It is caused actually by ischemia. It usually happens 3 to 4 weeks after the initial insult. They'll have an unexplained temperature, right upper quadrant tenderness, abdominal distension, and the treatment is cholecystectomy. In the GI system, there will be bacterial translocation. GI bacteria can leak into the circulatory system through the gut that becomes impaired or necrotic, or GI bacteria can go into the oropharynx and then aspirate, which would be vomiting, and then aspirating vomit, and then it will go into the lungs. They will have abdominal distension. This is because they will have decreased peristalsis. They'll have intolerance to feedings, hypobowel sounds, diarrhea. They'll have decreased cilia absorption of the water, and it's important to use the gut early. When we don't use it, we lose it, and to go past the pylorus. So this will be like a small bowel feeding tube or a J tube. Kidneys will be mimicking renal failure, or will be renal failure. It'll be ischemia secondary to decreased perfusion, nephrotoxic drugs, many of the drugs they're on that are damaging to kidneys. They will have oliguria or anuria, an increased BUN and creatinine, and dialysis. The heart, they will have myocardial depression. They can have hypotension, and they can need to be on pressors like dobutamine or norepinephrine. Coagulopathy they may have anemia, and because they have decreased perfusion to the bone marrow or decreased erythropoietin from the renal failure, they will have that decreased hemoglobin and hematocrit, and the treatment for that is blood. They may have DIC, which is microvascular clotting and organ hemorrhage, and these occur simultaneously. So they will have decreased platelets, and so we have to replace with platelets. They may have an elevated D-dimer. This is a byproduct of clot degradation. And we will give human protein C and also heparin. Cardiogenic shock is the first classification we'll talk about, and it is decreased ventricular pumping, which results in increased preload, increased afterload, and decreased contractility. They also this will result in decreased cardiac output and decreased tissue perfusion, and result in anaerobic metabolism. The things that can cause this are severe heart attacks, myocarditis, infections in heart valves, weakened heart muscle, and drug overdoses. The treatment for a high preload would be IV diuretics. The treatment for a high afterload would be an intra-aortic balloon pump. And the meds to treat decreased contractility would be IV digoxin and IV dobutamine. So this patient is going to have rapid breathing, severe shortness of breath, tachycardia, changes in LOC, weakened pulses, decreased blood pressure, sweating, pale skin, cold hands and feet, and decreased urine output. So we're going to do frequent assessments, decreased oxygen demand, and make sure they're resting. They might be on antidysrhythmics. We'll also do treatments to increase the oxygen supply to the myocardium. So this might be like a percutaneous coronary intervention, or angioplasty, or CABG, or ECMO. The next one is hypovolemic shock. This is a fluid volume deficit. So they will have decreased circulating volume, decreased stroke volume, then decreased cardiac output and decreased tissue perfusion, and then anaerobic metabolism. This can be caused by diarrheal diseases or trauma and large amounts of blood loss. So our treatment is to minimize fluid loss or blood loss, frequent assessments, watch for trending increased heart rate. So if it is fluid loss, we're going to treat with isotonic fluids. It might they will have aggressive fluid resuscitation. We might need to elevate the legs. They will have increased bun and creatinine. They might have hypernatremia. They also will have other electrolyte imbalances. In neurogenic shock, there is a decreased sympathetic tone, vasodilation. There is a decrease of baroreceptor response. This is the nerve receptors that are sensitive to pressure. There is impaired thermoregulation. Then there is blood pooling, decreased heart rate and decreased temperature, decreased cardiac output, decreased tissue perfusion, and anaerobic metabolism. For the vasodilation, we're going to give IV fluids. For the decreased heart rate, we're going to give atropine. And for the decreased temperature, we're going to give them warm blankets. They are going to become more dependent upon their environment for that thermoregulation. This occurs in patients with spinal cord injuries. The best thing we could do is prevent it by immobilizing their spinal cord and early detection of low heart rate and increased blood pressure. The next one is septic shock. There is an invading organism. There's excessive cytokines and bacterial toxins. There's vasodilation and altered coagulation. There's blood pooling and bleeding, decreased cardiac output, and decreased tissue perfusion and anaerobic metabolism. This is obviously patients with infections, and on the next 2 pages we'll review septic bundles and SIRS criteria. Anaphylactic shock, this is a severe antigen-antibody reaction. This can be due to inhaled, absorbed, injected antigens. There is a release of biomediators, and there are many, but one of them is histamine, and it will cause vasodilation, increased capillary permeability, bronchoconstriction, blood pooling, third spacing, and decreased cardiac output, airway obstruction, decreased tissue perfusion, and anaerobic metabolism. This is obviously patients who've had allergic reactions. So our goal is to remove antigens, reverse effects, and assess airway and skin. They may have the number one medication to reverse all 3 is epinephrine. We can also give IV fluids. They may need to have ET tube if they have the laryngeal edema. They may need, so epinephrine comes in 0.03 to 0.5 milligrams in an EpiPen, and it's in the 1 to 1,000 strength. If we're to give it IV, we will be administering the 1 in 10,000 strength, so make sure you understand we need the much more dilute version if we're giving it IV. They can also receive diphenhydramine IV, corticosteroids, fluids, and bronchodilators. The SIRS criteria is here on the right here, and you need to memorize that. And then the definitions of the different types of sepsis, severe sepsis, and septic shock are here for you to learn. This is a sepsis bundle. It shows you all of the things that you need to do in order. First, you need to recognize the symptoms of SIRS, notify the provider. Then you're going to complete 2 sets of blood cultures. They're drawn from 2 separate sites. These are recommended to be venipunctures. We don't want to use IVs or central lines for these tests. Also, you might need to be getting blood, urine culture, sputum culture, or wound cultures, depending on what's going on. You will also draw a lactic acid level, and then you will start broad spectrum antibiotics and IV crystalloids if necessary, if they're hyposensitive. And if they have severe sepsis or septic shock, you're going to do resuscitation with fluids, as well as all of those things. And if your MAP does not get greater than 50, then you will probably need to be doing some pressors, and you will be repeating your lactic acid after your boluses. This is just a nice infographic about the different sources of infections that cause sepsis and the signs and symptoms of sepsis. And I have some resources here regarding sepsis.